Hello, everyone. Welcome back to another week of Live from Home, our every other week town hall series that we started with the arrival of COVID-19 in New Mexico as a way for us to share important information and have good conversations about all the ways that COVID-19 is affecting and changing lives here in New Mexico. My name is Brian Egolf, and I am the Speaker of the House in the New Mexico Legislature. And we have been working on this project now for many months, and we've been lucky to have several times members of the administration and healthcare delivery system in New Mexico come on to give important updates on what's happening with COVID-19 in New Mexico, how the virus is spreading and progressing, and how the healthcare system is handling really unprecedented challenges. And I'm very pleased today that our State Secretary of Human Services, Dr. David Scrace, who is New Mexico's version of Dr. Fauci, and has become famous in his own right, is back with us to give us an update. We also have the state epidemiologist, Dr. Chad Smelser, who will also be telling us what's happening in the science of the virus as it works its way through New Mexico, and Dr. Denise Gonzalez from the Presbyterian Medical System, who is part of the operations center that was created between state officials and those in private practice to coordinate delivery of critical resources to COVID patients and make sure that the resources are being used where they're needed most and most efficiently. So we've got the public and private sector here today, and want to thank all of them very much for being with us. These are always very well attended and town hall meetings. The public is very interested in all of this, and we've been able to give some great information. I'd like to turn it over right away to Dr. Scrace for an update on where things stand. And Dr. Scrace, I'll turn it over to you. And maybe as I do, I should say that maybe Dr. Fauci is America's version of Dr. Scrace. That's maybe a more apt comparison. So, Dr. Scrace, we'd love to hear what you have to say, and thanks again for being part of today's town hall.
Thank you very much, Secretary Egolf. I'm honored to be here with Dr. Smelser Gonzalez. Pretty much anything you ever see me do is really the result of the work of many, many people. And frankly, I'm feeling less like Dr. Fauci and more like New Mexico's version of a piñata lately, trying to work to keep the virus down and to keep society socially distanced and masked and the like. You'll hear more about that. I'm going to share a little presentation today. Dr. Smeltzer and I are going to show you a few slides just so you have the latest information here, and we'll go through that fairly quickly. At HSD, we like to acknowledge before we start that we are, no matter where we are in New Mexico, on traditional lands of the first peoples of what's now known as our state of New Mexico, which includes its pueblos, tribes, and nations past and present. And I want to honor and with gratitude convey all of our respect for the land and these communities. I'm going to just turn this directly over to Dr. Smelser to run through this morning's epidemiology data, and then I'll come back in with a little bit more on gating criteria and the like. Chad.
Thank you, Secretary Scrace, and thank you, Speaker, for having me today. And thank you for all the attendees from the general public. It's an honor to be here. I'm going to start with just some slides depicting what's going on in New Mexico at present. And I will be available for some questions after the presentation and later on in the proceedings today. So just to give you an idea of where New Mexico stands compared to the rest of the United States, we are the yellow bar amidst all these red bars and then one gray bar, which is the United States averaged. And these are the infection rates of COVID-19. So the cases that we've had per 100,000 of our population over the entire course of the pandemic, which started on March 11th in the state of New Mexico in 2020 when we had our first case. So we are currently the 38th highest, which is good. We don't want to be over to the right of this. That means we have more and more infections. And that's testament to the work of the Department of Health, the rest of the state government, as well as the citizens of this great state who are adhering to our recommendations and staying safe. Next slide, please. Unfortunately, this isn't the most optimistic slide. This is our 7-day rolling average of the daily growth rate. So we're looking at what percentage are we growing cases in the state. That's what this graph means. The colored lines are the different regions of the state, and the black dashed line is the overall state. So all of those lines combined. The top line, the yellow line, is the Southeast. I think we advanced the slide. Great, is the Southeast, which we've been having our highest growth rates and our highest rates per population over the last month and a half. The bottom line, the gray line, is the Northwest. So at the beginning, that was where we were having back in May and April and May, the highest rates. That has remained low. It's plateaued. It has gone up a little bit recently. But the other thing to notice on this is that all of the lines except for the Northwest part of the state are all going up. And so that's obviously not a trend that we want to see. But we all need to work together to try to get those to come down. All right, so next slide, please. These is a slide that we call an epidemic curve. And so that's a categorization of the cases over time. So the bottom is the time, and the vertical axis is the number of cases. The bars that are in green are the cases that we count each day by specimen collection date. So that's the date when somebody has a swab put in their nose and the test is then sent off to the laboratory. The black dashed line is also the 7-day rolling average. And as you can see over to the left at the start of the pandemic, we had a gradual rise to our first peak, a little peak in between during a trough, and then a larger peak in July when we were having high numbers of cases. And then unfortunately, after a nice decline we've seen recently, since essentially after the first week in September, a steep rise, and we are gonna be over our peak in July. So we are gonna have a higher peak. The grayish area is where we're still collecting data and doing the investigations. It's not quite finalized. Unfortunately, it won't go down. If anything, it'll likely go up. We are in the midst of a big peak. And I think people understand that from the things they're reading in the media, et cetera. So next slide, please. This is what's going on in the metro region. So the metro region is Bernalillo, Sandoval, Valencia County, and Torrance. And as you can see, it mimics quite similar the distribution that you saw in the statewide, and that's because the metro region has our largest population. And so it drives what the state curve also looks like. But as you can see over to the right of this curve, we're in a steep increase in the metro region with very high case counts. Next slide. This is a Northeast region. Northeast region, if you look the magnitude, so how big are the numbers on the vertical axis are much lower than what you saw in the state and in the metro region, has been less affected by this pandemic, you might say, in terms of case counts. We're all affected by the pandemic, and has been lower and it's maintained itself. It did have a peak in July. It has had a long trough, but is on the increase, consistent with the rest of the state. Next slide. This is the Northwest region. I mentioned before that it had its peak early in the pandemic and then had a nice long decline and has maintained itself until recently when it's had some sort of undulating increases. We hope they don't suffer the same increased cases over the next few weeks that we've seen elsewhere in the state. Next slide. This is the Southeast region. Again, it was relatively unaffected early on, but the virus is sneaky and finds vulnerable populations and has moved into the Southeast, where we've actually had, per the population, because there's less people there, some of the highest rates in the last month and a half or so. And you can see they started to rise at the end of June, plateaued, kind of undulating, and then have had a steep rise as well more recently to the right of the graph. Next slide. In our Southwest region, you can see we had a peak there at the beginning, or excuse me, in the middle of July, and then it's gone down to a trough and has another steep rise. So all of these are relatively consistent with what we see in the overall state graph. I just will mention that there are a couple of bars that are different colors, yellow instead of the green. Those are detention center cases when we had large outbreaks in either our correctional or detention centers. We don't always count those in the county case counts when they're in correctional facilities, but they do obviously contribute significantly to the way the graph looks when we're looking at cases over time. Next slide. I just wanted to present a slide on deaths by week in New Mexico. We, of course, don't want any deaths, but we have seen over the course of this pandemic that we've had quite a few, and they're somewhat inevitable, especially when your cases go up. So these are deaths by week. And you can see we peaked early in April, had a decline, and then a corresponding increase in deaths that correspond with the peak that we saw statewide in the month of July, a nice decline. But unfortunately, we've seen kind of a leveling off or plateauing. And since we're having the steep increases in cases, unfortunately, I would predict that we will have some more deaths, and those numbers might go up. Again, this is more reason why people need to take as much precautions to prevent spread in their own homes, for themselves, their loved ones, and their surrounding community. Next slide.
Chad, I think this is where I take over. This is just another representation of all the data. Chad's already shown you at the dotted blue line representing all of New Mexico, each of the regions here. You can check the color coding. One thing to point out is that the Southeast has been the highest case counts for quite some time, but was passed last week by Bernalillo County. Now, there are more people that live in the central or metro region than there are in the Southeast, but so that isn't a big surprise, but Bernalillo clearly driving. And I would also just ask you to look, there's a lag here in the data, but look at the steepness of this slope. It is probably the steepest upward slope we've had so far, both in the central or metro region and overall for New Mexico, every single part of the state contributing to this uptick. These are what we call heat maps and show you by county. On the left, the total number of cases by county since the beginning of the pandemic. And I think we're expecting, Bernalillo in the lead, but they have the most people. And Doña Ana now really surging, probably will pass McKinley County sometime in the next couple of weeks, unless we see a lot more cases in McKinley County. And this is just the last 2 weeks. Two things that I like to look at here is where is the darkest color, and first thing your eye is drawn to is the metro regions of Bernalillo County and City of Albuquerque, Doña Ana County, and Las Cruces, and then the southeastern part of the state, this darker color here. The other thing that Chad reminds me of is that when you look over the last couple of weeks, 30 counties have reported cases, and this is what we see. When we start seeing more uncontrolled community spread, we see 25, 28, 30 counties reporting new cases in a single day. And we're seeing that slowly growing and increasing now. And this is another version of the cases in green, the hospitalizations in gray, and deaths in red. And what we have noticed, particularly in the second peak, and now in the third peak, is there's about a 2-week lag between when cases start to rise and when hospitalizations start to rise. and about a 2-week lag between when hospitalizations start to rise and the death count starts to go up. So, and we always, in these early periods like here, we always get a lot of questions like, well, COVID must not be as lethal or must not be as problematic because we have this huge number of cases, but hardly any hospitalizations and no deaths. And unfortunately, I hate to say it, but the answer generally to that question is, well, let's just wait 2 weeks and see, because we will expect hospitals to climb. And in fact, this morning, our Albuquerque hospitals, UNM, well over its maximum capacity, pressing very hard, Loveless just a few open beds. And so issues ahead. Another slide, which I don't think got in here to this deck, but another thing we're seeing is an increase in case counts in all age groups. You remember the first peak, this green dotted line, it was older people, and then this peak was driven more by younger people, but this peak is driven by everybody. And we're seeing fairly steep upticks in all age groups. And that's particularly worrisome. I think we noticed yesterday that we had more cases in people over 65 than we ever have had during the pandemic. And that age group in particular drives hospitalizations along with the 55 to 65-year-old age group as well. I'm going to skip this slide just in the interest of time. We do monitor mobility, and you can see that we were running, these are by regions. They're a little bit different, but our overall mobility by every county dropped precipitously, hitting a low point. It turned out to be Easter Sunday in mid to late April. And then there was a steady rise. And then we hit the peaks that we started to see at the end of June, early July. Things stabilized, but I'm a very much an optimistic person. My glass is always half full, but I got to say now, looking at this data, that every region seems to be slowly rising in the mobility. And the reason we show the slide is mobility is one of the best predictors of case growth. We have gating criteria. We use them to determine when it's safe to reopen. They're based on the spread of COVID, our testing capacity, contact tracing and isolation, and our statewide healthcare system capacity. We're already obviously red in our 2 spread rate, both the number of cases and the rate of spread. Test positivity has recently crept over our target of 5, and now we're at 5.55. And however, we're still holding our own with testing and doing a great job in terms of the number of tests. Contact tracing for the week ending last week was still keeping up. I don't mean to lay crepe or say anything about the work Chad and his team are doing, but this is certain to get longer with 500 cases. You can't possibly track down people every day when you have 500 cases. And then lastly, the hospitals not yet showing the numbers that would put them over their baseline. Just a reminder to all of you as well that you can just go online and look at these gating criteria whenever you like. Everything that we're showing you today is available someplace, although some things we only update once a week. But if you want to see what's happening with the test positivity rate, for example, you click there, you can read all about the measure, and you can see where we've now crossed back over that line. We're now dark red again. It pains all of us on to both the delivery side and the public health side to see us back in the dark red with this increase in case counts. I like to talk about this map and these numbers a lot when they're green, but I'm going to move on. And then here's a little movie that we've prepared for you. We started looking at the red, green, and orange and yellow counties, red being high case counts, high test positivity rates, orange being high case counts, good test positivity rates below 5%, yellow, high test positivity rate, low case counts, and green being good on both. And this is one of those, like the CDC map of obesity in America. I'm trying to make it into a movie so you can just watch what happened over 2-week periods. This is the last 2 weeks of August, and then how it evolved second to last week, or last week of August, first week of September, another week, doing good, looking good, another week. Now we have more red. And now I believe this is the most, no, it isn't, not the most recent. some counties turning orange. And so this is the one for today. And so we've come a long way. And now all of these counties, including Bernalillo, in the orange with high daily case counts. And so that's a problem for us. I also just want to reinforce because I know there's some legislators on the call, and some of you, are representing districts with very low percentage of people in poverty, and others, probably most of you, representing districts with a very high percentage of people in poverty. And the chances of having COVID, if you live in this is a census tract now, but it's still the same point. It's just the unit of measure we have. If 40% or more people in a census tract are below the federal poverty limit, you have 6 times the chance of having COVID as you do if you live in a census tract with very little poverty. Really important issue when it comes to Medicaid. It's why taking commercial insurance data and trying to apply it to Medicaid is absurd. There's no correlation at all. Here are your commercial customers here. Here are your Medicaid customers here. And so we're working really hard to ensure these people get care. And if that weren't enough, and I don't want to go through this because it sort of focuses on behavioral health, but what this basically says is in the general population, about 8.8% of people have high blood pressure. In people with a behavioral health diagnosis in general population is 13.9. In Medicaid, those numbers are 7 and 26.3. So every one of these, hypertension, arthritis, diabetes, chronic kidney disease, Medicaid is of 2 times or more multiplier for the incidence of disease. And people sometimes complain to me that the Medicaid benefit is too generous, but it is constructed the way it is because of numbers exactly like these blue bars here. Okay, off my soapbox. And that's it, Mr. Speaker. And Alex put Chad's slides at the end, but I moved him to the beginning. So any other, I think we're all open for questions. I wanted to turn it over to Denise. She did a really amazing job organizing the delivery system in the May, June, July period. We stood down that call center. It is coming back up again under all the auspices of DOH, I believe this week, but she's been an integral part. And I don't think we could do anything that we're doing in the state or would have been anywhere near the success we've had were it not for the active collaboration and really partnership between our delivery system. I didn't talk about the MAT today, but I could take you through hundreds of pages of documents that private physicians, university physicians have given up their very valuable time during a pandemic to help us organize policy and recommendations. So Denise, what would you like to say today?
Well, thank you, Secretary Grace, and thank you, Speaker Golf, for inviting me. It's an honor to join all of you. I wanted to go over historically what we've done for those of us who are delivering care directly to patients. And I think it's informative to look at the history of the last 7 to 8 months. So when we started the pandemic, we started with a couple of therapies that some of you may recall. We used hydroxychloroquine and azithromycin. Hydroxychloroquine is a medication that's used to treat patients with autoimmune diseases like rheumatoid arthritis. It's been studied in that disease. And azithromycin is a very common antibiotic. I think there was a lot of hope for that, and many of us use the medication, although it hadn't been studied. And I would have to say that the state did an exceptional job in preparing for this, because there was a fear that we were going to run out of hydroxychloroquine, and those patients who needed it to treat their rheumatoid arthritis wouldn't have access to it. So great kudos to the state to reaching out to those of us on the delivery side to ensure that those patients were also well cared for. Unfortunately, after a couple of months of looking at the data and looking at side effects and bad outcomes, we did find that hydroxychloroquine used to treat COVID in the doses that we used had some harm associated with it. It had to do with effects that it had on the heart. And so we stopped using it. We have continued to use azithromycin, however. The next phase was around the use of remdesivir, which is an antiviral medication that's been studied to treat other viruses. And the hope was that it could be applied to coronavirus as a novel virus. We're still evaluating the data. On the delivery side, we still commonly treat patients with remdesivir, but they have to meet the criteria for the use of remdesivir because it's not been widely studied for just broad application. So when patients are sick enough to be admitted to the hospital because they need oxygen supplementation, IV fluids, and so forth, they generally meet criteria for the use of remdesivir. Again, working with the state did a great job of making sure that we had a good program around allocation for remdesivir so that we didn't have people stockpiling, hoarding, using inappropriately. So we all pulled together through the MAT, which is the statewide committee, to make sure that remdesivir was sent to the appropriate hospitals to treat patients who really met criteria for the use of remdesivir. All along, as pulmonary critical care physicians, we've been using steroids. Steroids are very well studied, and we use them for the indication of a disease state called ARDS, or Adult Respiratory Distress Syndrome. So steroids are not new, but we have had enough experience to look specifically at the use of steroids in patients with COVID-19. And we are seeing that using steroids in COVID-19, much like when we use it for ARDS, there's a benefit. There's increased survival, there's decreased time on mechanical ventilation, and improved rates of surviving to leave the hospital. As we've gone along, we've had other therapies like convalescent plasma. Convalescent plasma essentially takes the plasma from patients who have successfully recovered from an infection. It's a therapy that's been used before for other viral infections. For example, for West Nile virus, we take convalescent plasma from pools of patients who have a nice response to form antibodies against West Nile, and we use that as a therapy for patients with new West Nile infections. So we thought to translate the use for West Nile and then apply it in COVID-19. Those hospitals in the state of New Mexico that are using this therapy are participating in national trials so that we can collect the data and look at outcomes. And I think that that's very important, that we not just willy-nilly grab everything off the shelf and apply it randomly to people. The data is yet to come. I think it's very complex. I think specifically we assume that because a patient was successful in their response to an infection, that if we take that gold from them and apply it to another patient, that it'll have the same benefit. But as humans, we're very complex and we're very diverse. And so we all have different genes that cause us to respond differently to infections. So it's yet to be known. It seems to be safe. We haven't seen any of the reports of adverse effects the way we saw with hydroxychloroquine. So we are continuing to use convalescent plasma. Then I want to go on to the next new thing and talk about monoclonal antibody cocktails. It's much like the convalescent plasma approach. In convalescent plasma, we take everything that patient made in response to the infection and then transplant it into another person. With monoclonal antibodies, we select a few specific proteins that we think play the majority of the role in clearing the COVID-19 infection. We make them in a lab, put them together in a cocktail, and then deliver them to the patient in an IV form. I think that, having myself worked at the NIH, I think there's a lot of hope for those types of therapies, these targeted immunotherapies. But I think it's important for those of you on the call to understand that this is very much experimental. It is not FDA approved. It doesn't even have an emergency use authorization around it. So I want to make sure that everybody has the expectation and understanding that if you see me in the hospital and I'm not offering you monoclonal antibodies, that it's not that I'm withholding anything from you. This is an experimental therapy that is not approved. We will, however, continue to use drugs like remdesivir and use steroids if you've developed ARDS. And for certain patients who could benefit from convalescent plasma, we'll also enroll you in the trial and get some convalescent plasma in to see if we can bring about the speediest recovery possible.
Thanks, Denise.
Yeah, thank you. We've heard, of course, in the last few weeks, because of a person that has been referred to as a well-known individual who underwent treatment after a COVID-19 diagnosis. We've heard the brand name Regeneron. Can you tell us what is that, and what is, if anything, happening with that in New Mexico?
Yeah, so Regeneron is the company that makes one of these monoclonal antibody cocktails that I referred to. So it's a trade name, it's one specific company. But the approach would be similar for any other company that's devising a monoclonal antibody cocktail. I'd like to just emphasize that it's experimental. And having come from a research hospital, I think that all of these therapies are intriguing and many of them bear out and are quite effective. But at this point, Regeneron's product and any other monoclonal antibody for COVID-19 that are out there are still experimental. We don't have safety data and we don't have any information that tells us whether it's even effective.
Thank you for that explanation. And while it's clear that treatments are improving, I think it's fair to say that we, as of yet, lack a cure. Is that correct?
Yeah, we do lack a cure, and I think that it's important for us to reflect back on recent history. You know, we've had 2 novel influenza virus outbreaks worldwide in the last 10 years. And we did look for therapies that could be used against these novel influenza viruses. We had the benefit of having an influenza vaccine that could be quickly reformatted to target those novel influenza viruses like swine flu and bird flu. It's quite different with COVID-19. And so the last therapy that I didn't mention was a vaccine. And so if Dr. Smesler wanted to comment on vaccination or Dr. Scrace, I'd welcome their input.
I think we'd be very interested. Dr. Smesler, do you have any news about the race for a vaccine?
Well, I think most people have heard the terms Operation Warp Speed, and that is a federal push to develop vaccine rather rapidly. We in New Mexico want to make sure that anything that's developed, rapid or not, is safe before we give it to the citizens of the state or allow them to receive it. So just that blanket statement up front. The state is also has a team of professionals that is from the Department of Health and healthcare systems around the state, as well with federal partners to develop a vaccination plan. So assuming we do get a vaccine sometime in the near future, how are we going to prioritize it, get it out to the public through distribution sites, et cetera. So those plans are in the work. I don't think we have time to discuss those details. They'll be forthcoming though when the vaccine is closer on the horizon. I did see an interesting headline about, I don't remember the company, but one of the companies, another company, stopping their vaccine trial. And the headline was, great, the vaccine trials are working. And they actually meant that. What they meant was people are stopping and looking and saying, are these safe? And so if they see an adverse outcome, they want to stop their trials, evaluate what's going on before they proceed. So we keep hearing in the national news that we're going to have a vaccine soon. That may very well be true, but we are not going to have a vaccine in the quantity with appropriate safety studies behind it that will be comfortable to deliver right away to New Mexicans until we're able to evaluate that data on our own.
And I would just add that when I think about this and the distribution channel and the complexities and different requirements for different vaccines, I think, you know, and I actually was just talking to all the employees in the Human Services Department an hour ago. I'm telling them that I think we're going to be in the mode that we're in right now for probably another year. You know, I sort of have, you know, end of September next year in my mind is maybe by then we'll get enough people vaccinated. But for those of you who are just kind of counting the days until we just get back to normal life, one, that might never happen. And two, it's more days than I think any of us were thinking. I mean, it's whatever, let's see, today's the 14th. So it's about 351, at least in my brain. And I'm sure, I hope to be proven wrong. And I hope to be proven wrong because it's earlier than that. But I think that's my working hypothesis. I don't know, Dr. Smelser or Dr. Gonzalez, do you have like a thought about that? Or a number in your head about?
I wanted to comment on the vaccine. I am very encouraged by the fact that the trials are working as designed because it is important for us to study therapies in a very controlled way. And I'm also glad to hear that the studies are being halted to reevaluate, because that follows the way that we do science. And to reassure the public that we're not just sitting back and waiting for the vaccine to come around and then we're going to start planning. You know, working with Dr. Scrace, the MAT, the rest of the state's DOH, we're preparing already for how we're going to distribute the vaccines and doing very careful planning so that the day that it becomes available, we'll be able to start delivering doses.
Right.
Well, gosh, you know, the end of September forecast, you know, Dr. Smelser, you know, what might you think about how long we're going to be in this mode?
You know, it's very difficult for anybody to really truly give you a timeline. And so, I wouldn't want to give one that, you know, would not be true to my heart. So I think the best thing that I would say is until we have a vaccine that's proven or enough herd immunity, so enough people who've been infected that it actually provides some immunity in our communities overall, we are going to continue to see a COVID activity. When we talk amongst our staff, we talk about bracing for the long haul, for the marathon. I don't think we're going to get a quick fix anytime soon. So when Secretary Scrace is talking about another year, I don't think that's, you know, not true. I think that's more likely than anything. And it might go even longer than that, unfortunately. Just hopefully not to the same level that it's currently at.
Right. Well, we have a few questions from folks that are watching online. And one of the questions kind of goes to a little bit of the duration and some of the effects that they're having. The first question is from C.W. Ward, who has a question about youth sports. He says he's a soccer coach and is curious about what data and criteria are being used with regard to the decision about youth sports. Is there a difference between contact sports like wrestling and football versus soccer, and how is that decision made to have youth sports not proceed in the fall?
I'm going to start just talk about the general question. We get a lot of questions of, well, what data do you have that says we shouldn't be doing this? Or what data do you have that says we should do A and not do B? And just a reminder, this is the novel coronavirus, and novel means new. And that means we don't have that much data. I mean, at the very beginning, the state had almost no data on the coronavirus, and the preponderance of opinion was in some really critical issues was, in my opinion, in the wrong direction. Masks weren't effective. You couldn't transmit the disease if you didn't have symptoms. I mean, a whole bunch of things that we kind of from a scientific and epidemiologic and previous pandemic experience rejected and said, that doesn't make sense. So the question I always ask back to people who ask questions of what data do you have that says this isn't safe? Like if you have data that shows that youth sports and high school football is safe, please send it to us, because we're scouring the literature every single day and we're not finding it. And so the answer to a lot of questions of what data you have is, we don't. I will say that when we do have data, we use it. We apply it in whatever way we can. We judge the quality of it. And there's some weaknesses in the quality of scientific data, but that's gotten a lot better in the last couple of months. We're seeing better studies now. We apply the data whenever we have it. And when we don't have it, we try to rely on our best judgment and fundamental epidemiologic principles and what we know about how COVID spreads, which very simply is 2 or more people being in the same place, breathing the same air. That pretty much sums it up 99% of the time. And so a lot of our decisions about, is it safe for kids to tackle each other and be breathing hard and shouting and playing on a football field, come from what we, as an extension of what we know about how the disease spreads and examples of widespread disease as a result of a single event. That being said, I know Chad has a passion for youth sports. I certainly would love to see kids back out there in the field. But at the same time, we don't know the long-term effects of COVID. And there's some sort of worrisome stuff out there right now. So Chad.
Yeah, I actually don't have too much to add, and I know we have more questions. I would just implore the coach and everybody out there that if you are participating in youth sports and are allowed to do so, that you absolutely adhere to all of the safest practices that you possibly can. I do have experience with soccer for the most part in youth sports, and I have seen recently teams out practicing where they're not actually doing the full safe practices, and coaches pulling down their mask in order to talk to their team, which is exactly what you don't want to do. That's when you for sure want to wear your mask, because you're projecting your voice and you could be spewing out particles that could be infectious. So I just implore, when and if we all want to see kids back out playing, everybody enjoys that. At least the majority of people enjoy that. And we really would like to see that. People need to, though, continue adhering to all the safe practices. Otherwise, they're not going to be able to get out there and play, and nobody wants to see that.
The state does have a guide to COVID safe practices that's available online, and I encourage you to look to that. It's a great handbook for an increasing number of different situations, including youth sports.
Okay. It seems that a lot of the things that folk, I've mentioned on these forums before. I've got 2 young daughters who are involved in distance learning, and I am very aware of the challenges that are presented to families and parents and students across the spectrum, not just sports, but math and all forms of instruction. And it's to say it's hard is a massive understatement, and hard on the kids. And I kind of come back to we need to understand that the Lujan Grisham administration and everyone that's working as part of that, with our private partners like Dr. Gonzalez, are making these decisions about restrictions or changes in how we interact with one another, not to be punitive, right? The decisions are being made to save lives and to try to get the virus back into a state of control, that we can have some bits of normalcy back in our life as we await a vaccine. And I realize this is not really in direct answer to a question, but it does bother me that we see folks who don't really have much of a grounding in science or medicine wanting to pin the blame on the governor and her administration, when the blame belongs on the virus and on a failed federal response from the early days. And we're doing the best that is possible, and it's hard, and there's just no two ways about it. It's really tough. Dr. Gonzalez, we have a few questions about hospitalization. What is the, how many people do we have hospitalized for COVID in New Mexico right now? How are emergency rooms handling the situation? How are the ventilator supplies? I'm sort of summarizing several questions that we've gotten, but if you could tell us what things look like and how you see things developing over the next few weeks with regard to hospitals and emergency rooms and ICUs in New Mexico.
Yeah, I think fortunately over the last 7 months, we've been able to address any issues that we had in terms of supplies, how to best use our PPE, our personal protective equipment. We all seem to have sufficient stockpiles. We've also addressed the issues of ventilator count. So I think we're in a much better place now because we've done the exercise in reality, and we are prepared in that regard. I'm expecting, because of the numbers that Dr. Scrace and Dr. Smessler just shared, that 2 weeks from now we're going to see an uptick in hospitalizations and probably another couple of weeks delay in terms of patients who are in the intensive care unit. That's what we experienced in the past. Today, on a call that we did this morning, the major hospitals across New Mexico that have intensive care units in the south, they're at between 80 and 90% of their usual occupancy in their intensive care units. In Albuquerque, the university is at 120% of its ICU capacity, and it's holding many patients down in the emergency department waiting for an ICU bed to become available. Presbyterian is close to 90% of ICU capacity, and Lovelace is about the high 80s in terms of ICU. Just like we saw with the previous wave, what we're experiencing is that it's not necessarily the ICUs getting locked up first, but it's the whole rest of the hospital. We have to take care of usual care patients who are coming in for their routine surgeries and routine care, and then lay on top of that the increased rate of infection and need for hospitalization. I'm concerned about our ability to distribute patients throughout the state, because this time around, as opposed to last time, the entire state's ICU capacity is relatively full. In the first phase, it was all coming from the Northwest, and the South had a lot of capacity available. We did send patients down to the South a few times, not very much. Now I think we're having to consider how we're going to pull patients out of the South into central New Mexico instead, because they don't have their usual outlets of being able to transfer to Texas.
You're saying that Texas is closed to do admissions from New Mexico.
That was the word that I received this morning, was that the adjacent counties to southern and eastern New Mexico are closed to transfers from New Mexico.
Now, when you say that capacity is 120% at UNM, not being in medicine, I hear that number and I think that sounds like a crisis. Could you give a little context to what it means for UNM to be at 120%?
Yeah, it is a crisis. Unfortunately, our state's hospital is frequently at or above their usual licensed capacity. But being at 120%, that's really a situation where you're putting 2 patients into one ICU room, holding lots of patients in the emergency department and trying to deliver ICU level care to them. It's why we pulled together the last 2 days to intentionally pull patients out of UNM so that UNM is available to continue to care for patients, because UNM plays a very important role in our state. It's our only level 1 trauma center. And so in order for New Mexico's level 1 traumas, which are major car crashes, for example, it's very important for the rest of us to be helpful, pull together, and help shift patients out of UNM so that UNM can continue to take incoming of patients who can only be treated there, that we can't treat at Lovelace, Christus, St. Vincent, or Presbyterian.
Mhm. And the governor's office just announced, I'm sure Dr. Grace and Smelser, you knew this, but 577 new cases reported today in New Mexico. So we've only got about 4 minutes, so I'll ask you, whoever would like to answer. But we know the importance of wearing masks when we're out. I tried to get by on my jogs with one of those plastic face shields so I could breathe while I was running, but no, I'm told not. I see your head shaking, Dr. Grace. I wasn't watching, but a colleague of mine in the house sent me a text. They said Dr. Grace is dissing on your face shield, so no more of that. And so I've stopped. I've not done the face shield since, Dr. Grace. But can you, I imagine there's a lot of New Mexicans who are going to be very concerned and very worried about this. And what can we do? What can average everyday New Mexicans do to play a role in bending the curve back down?
Let me just say a few words, and then I'll ask Chad and Denise if they have additional comments. I think it's really the same playbook. I like to say this. I don't feel very confident saying it today, but I actually believe if everyone wore a mask and we kept that 6-foot distancing, we all had masks on anytime we were out of the house. We didn't do anything indoors outside our own home with our masks off, and avoided unnecessary trips, took the safest route of every option, like groceries. If you can do doing pickup and having them put them in the trunk, I think we'd be running 40 cases a day till we're all vaccinated. But what varies in New Mexico is the number of people who can just really face it. Nobody can really stand it anymore. It's just being at home and wearing a mask and not getting to do stuff. People are kind of fed up. I still hang in there, but I would have to do it even if I didn't feel like it. But it's really the same exact things when you're in a room or in a space. It could be outdoors with someone and you're close and you don't have masks on, or you're breathing the same air. That is how COVID transmits. And so just less of those person-to-person interactions is what we need. I'm going to let Chad wrap it up.
Do we know, based on contact tracing or based on data, what types of events or what types of interactions, or do we know, are there certain types of interactions or events that have led to a large percentage of this increase? Is it backyard barbecues? Is it people gathering in confined spaces? Is it people exceeding 25% in a restaurant? Do we know that there are certain things that are identified as being a large contributing factor to the surge we're currently experiencing?
This is one of Dr. Smelser's
Yeah,
favorite things to talk
I'll start the answer for this. So what we know is indoor is riskier than outdoor. Indoor with no mask on, riskier than indoor with a mask on. So we need people to, and in general, any setting where you're doing, where there's person-to-person contact, there's the potential for spread. There's a few cases where you have really good PPE on, that personal protective equipment that can prevent that. But in general, for the public, you want to prevent interactions with other people. That's how you decrease spread in your general community. So anything you can do to do that. So Dr. Grace gave some examples of having groceries being delivered to your car or delivered to your home instead of you going into the grocery store. We have seen a lot of cases associated with family gatherings and other types of gatherings, especially around holiday weekends or during the summer months when people normally travel. So those types of gatherings are very dangerous because people tend not to wear masks the entire time. They congregate in larger groups. They get within 6 feet of others, and they often do things that we like to do with those. They have a drink or two, or they have some food and snacks, and they take their masks off. So I can't, implore people enough to wear masks, to stay 6 feet away from others when you're out in public, and to wash your hands frequently.
Well, that's good advice on which we'll have to end today, we want to always be respectful of everyone's time and schedule. I deeply appreciate Drs. Grace, Smelser, and Gonzalez for being with us this afternoon. The information is helpful and timely. And as I always end each of these broadcasts, I'll say again, please, folks, it is beyond the point at which we need to be imploring everyone to stay at least 6 feet apart, wear your mask, don't leave your house unless it's necessary. As the governor said last week, we want to keep in mind that triangle of, try to do just one thing when you leave your house and come back as quickly as possible. The evidence is showing that this surge is continuing to worsen, and that will continue until we can all take responsibility for ourselves and our families and our communities by doing the incredibly simple things of staying apart, wearing a mask, and washing your hands. That's all it's going to take to get back to where we want to be with this virus. And the longer it takes for our population to start doing those very, very simple things, the longer it's going to be before we can see light at the end of this tunnel. And as we go into the colder months with people being inside more, we have to be even more vigilant about following all of these guidelines to keep our people safe. And the life you save could be yours or the life of a loved one. We kind of let our guard down, and we've got to get back to being vigilant so we don't see things worsen even further. So please wear your mask, wash your hands, stay in that triangle. And until next week, God bless you all. Stay safe, stay healthy, and have a good rest of your week. Thanks so much. Bye-bye.
Goodbye, everyone.